Welcome to an exploration of one of history's most dramatic transformations. The journey from medieval surgical practice to modern operating theaters. A story not of steady progress, but of catastrophic failure, accidental discovery, and the stubborn resistance of educated men who watched their patients die rather than abandon centuries of tradition. In the year 1346, a barber surgeon named John of Ardern stood in a dimly lit chamber in Newark, England, preparing to perform an operation that would have terrified any modern observer. His patient, a knight suffering from an anal fistula, lay conscious on a wooden table, while Ardern sharpened his knife on a leather strap. No anesthesia existed beyond perhaps some wine or a leather strap to bite. No concept of sterilization guided his hands, and no understanding of infection would explain why so many of his patients would die screaming in agony days after what seemed like successful procedures. This was not the work of an ignorant butcher, but of one of medieval Europe's most respected surgeons, a man who wrote detailed treatises and trained apprentices across England, and his methods represented the absolute pinnacle of surgical knowledge in his era. The distance between Ardern's blood-soaked workspace and a modern operating room is not merely technological, it is philosophical, scientific, and almost incomprehensibly vast. And understanding what changed between these two worlds reveals one of humanity's most hard-won victories against suffering and death. Medieval surgery was not simply primitive modern surgery. It was an entirely different system of understanding the human body, disease, causation, and healing, built on foundations that were simultaneously logical within their framework and catastrophically wrong in their conclusions. The story of how we moved from one world to the other is written in the bodies of millions who died from infections that modern antibiotics cure in days, in the screams of patients who endured amputation while fully conscious, and in the slow, agonizing realization by a few pioneering physicians that everything their profession had believed for over 1,000 years was killing their patients. Medieval surgical practice in the period from 1100 to 1600 operated within the theoretical framework of humoral medicine inherited from the ancient Greek physician Galen, whose teachings dominated European medical thought with almost religious authority. Surgeons believed the human body contained 4 essential humors: blood, phlegm, yellow bile, and black bile, and that illness resulted from imbalances among these fluids. This meant that surgical intervention was designed not primarily to repair damaged tissue or remove diseased organs, but to rebalance the humors through bloodletting, purging, or the application of substances believed to draw out corrupted humors. When a medieval surgeon like Guy de Chauliac, the papal physician at Avignon in the 1360s, approached a patient with a compound fracture, his primary concern was not preventing infection, a concept that would not exist for another 5 centuries, but managing the humoral imbalance that the injury had supposedly created. De Chauliac would examine the wound, note the color and consistency of any discharge, smell it to determine which humor was predominant, and then apply treatments designed to restore balance. If the wound appeared too moist, indicating excess phlegm, he might apply drying powders made from ground minerals. If it seemed too hot and red, suggesting excess blood, he would perform bloodletting by opening a vein or applying leeches. The wound itself would be packed with materials we now know were catastrophically contaminated: linen soaked in wine or vinegar, poultices made from bread mold and honey, or plasters containing ground herbs, animal fats, and sometimes pulverized precious stones believed to have healing properties. The surgeon would then leave the wound to heal by what they called laudable pus, a thick, white discharge that medieval physicians believed indicated proper healing. In reality, this laudable pus was a massive bacterial infection, and its appearance was a sign that the patient was likely to die within days, but because some patients with minor infections survived. Medieval medicine enshrined suppuration as a necessary and positive stage of healing. This catastrophic misunderstanding killed untold thousands, as surgeons actively worked to promote the very infections that modern medicine fights desperately to prevent. The medieval surgical toolkit reveals both impressive mechanical ingenuity and shocking ignorance of basic biological principles. John of Ardern's illustrated surgical treatise from 1376 shows dozens of specialized instruments, curved needles for suturing, cautery irons for burning closed blood vessels, trepanation drills for boring holes in skulls, retractors for holding open incisions, forceps for extracting arrows and other foreign objects, and an array of knives in different sizes and shapes. These instruments were often beautifully crafted by skilled metal workers, with decorated handles and precisely ground edges, but they were almost never cleaned between patients in any way that would remove infectious material. A surgeon might wipe his knife on his apron, already stiff with the dried blood and pus of previous patients, or rinse it quickly in a bucket of water that had been used for multiple procedures. The very concept of invisible organisms that could transmit disease from one patient to another did not exist in medieval thought, so there was no reason to implement what we now understand as basic hygiene. The surgical theater itself was typically a private chamber in the surgeon's home or shop, or sometimes a space in a monastery or hospital, with minimal light from windows or candles, no running water, and floors covered with rushes or straw that absorbed blood, vomit, and other bodily fluids. The air would have been thick with the smell of unwashed bodies, rotting flesh, cauterized tissue, and the various herbal and mineral preparations used in treatment. Surgical assistants, often apprentices or barbers in training, would hold down the conscious patient as the surgeon worked, their hands moving from restraining one screaming patient to assisting with the next procedure without any washing or barrier protection. The mortality rate from major surgery in medieval Europe has been estimated by medical historians at between 60 and 80%, though reliable statistics do not exist. What is certain is that most patients who underwent amputation, abdominal surgery, or major wound treatment died within a week, usually from what we now recognize as sepsis, a whole-body infection that medieval physicians interpreted as a fatal humoral imbalance. The absence of effective anesthesia shaped every aspect of medieval surgical practice and limited what procedures surgeons would even attempt, while various substances were used to dull pain, including wine, opium poppy extracts, mandrake root preparations, and mixtures called soporific sponges soaked in narcotic plant extracts. None provided anything approaching the complete unconsciousness that modern general anesthesia delivers. The most common pain management was simply restraint and speed. Patients were held down by several strong assistants while the surgeon worked as quickly as possible. An experienced surgeon could amputate a leg in under 2 minutes, cutting through flesh and muscle, sawing through bone, and cauterizing or tying off major blood vessels before the patient died from blood loss or went into fatal shock. The screams of surgical patients were considered simply part of the procedure, and many medieval hospitals and surgical practices were located in areas where the sounds would disturb the fewest neighbors. This situation created a profound moral and practical dilemma for medieval surgeons. They knew their procedures caused extraordinary suffering. They could see that many patients died, and yet they also saw some patients survive and recover, which seemed to validate their methods. The few voices who questioned whether surgery did more harm than good were generally ignored, because the alternative, doing nothing, also resulted in death for patients with severe injuries or advanced diseases. Medieval surgery existed in a tragic space where intervention was often fatal, but non-intervention was certainly fatal, and the intellectual framework did not exist to understand why this was true or how to change it. The transformation from medieval to modern surgery did not happen through a single breakthrough, but through 4 separate revolutions that occurred over roughly 300 years, each one removing a major barrier to effective surgical treatment. The first revolution was anatomical understanding, driven primarily by the work of Andreas Vesalius, who published De Humani Corporis Fabrica in 1543, based on careful dissection of human cadavers rather than reliance on ancient texts. Vesalius demonstrated that Galen had been wrong about fundamental aspects of human anatomy, including the structure of the heart, the course of blood vessels, and the function of various organs. This work, expanded by William Harvey's discovery of blood circulation in 1628, gave surgeons for the first time an accurate map of the territory they were cutting into. The second revolution was anesthesia, which arrived suddenly in the 1840s with the nearly simultaneous discovery that ether and chloroform could produce complete unconsciousness, allowing surgeons to work slowly and carefully rather than in a frantic race against pain and shock. The first public demonstration of ether anesthesia at Massachusetts General Hospital in 1846 was described by witnesses as miraculous. A patient underwent a major neck surgery without apparent suffering, and surgeons immediately recognized that this changed everything about what was possible. The third revolution, and perhaps the most important, was antisepsis and later asepsis, the understanding that microorganisms caused infection and that surgical technique must be designed to exclude or kill these organisms. Joseph Lister's adoption of carbolic acid spray in the operating theater in the 1860s, based on Louis Pasteur's germ theory, reduced surgical mortality rates from over 50% to under 15% within a few years, and by the 1890s, the principles of sterilization, surgical gloves, masks, and gowns had become standard practice. The fourth revolution was the development of effective antibiotics, beginning with penicillin in the 1940s, which meant that even if infection occurred, it could often be cured rather than being a death sentence. Each of these revolutions faced intense resistance from the medical establishment, which had built careers, reputations, and teaching systems on older methods. When Ignaz Semmelweis demonstrated in 1847 that hand-washing with chlorinated lime solution reduced maternal mortality in childbirth from 18% to less than 2%, he was mocked, ostracized, and eventually dismissed from his position, dying in a mental institution in 1865, his reputation destroyed. The medical community could not accept that physicians themselves were killing patients by transmitting infectious material from autopsies and other patients. The idea was seen as insulting to the dignity of educated doctors. Similarly, when Lister first proposed antiseptic surgery, many surgeons rejected it as unnecessary fussing that slowed down procedures and introduced unpleasant chemical smells. Some prominent surgeons continued operating in their street clothes with unwashed hands well into the 1880s, even as statistical evidence mounted that Lister's methods saved lives. The resistance was not simply ignorance or stubbornness, but reflected how completely the older paradigm shaped thinking. If you truly believed that disease came from humoral imbalances or miasmas in the air rather than from invisible organisms, then washing your hands or sterilizing instruments seemed pointless, and the revolutionary new ideas seemed to contradict centuries of accumulated medical wisdom. The transition required not just new techniques but a complete reconceptualization of disease, the body, and healing, and such fundamental paradigm shifts always meet resistance from those whose expertise is invested in the old framework. The comparison between a medieval surgery and a modern procedure illuminates the distance traveled. Imagine John of Ardern in 1370. Attempting to repair an intestinal obstruction, he would open the abdomen with an unsterilized knife in a dim room, the conscious patient screaming and restrained by assistants. Ardern would explore the abdominal cavity with unwashed hands, identify the problem by feel, and attempt to manipulate the intestine back into proper position. He would then close the incision with silk sutures, pack the wound with herbal poultices, and leave it to heal. The patient would almost certainly develop peritonitis within hours, as bacteria from the intestinal contents, the surgeon's hands, and the contaminated instruments spread through the abdominal cavity. Within 3 to 5 days, the patient would die in agony from systemic infection, and Ardern would record the death as resulting from an imbalance of humors or perhaps divine will. Now imagine the same procedure in a modern operating theater. The patient arrives fasting and sedated, is moved to a room where the air is filtered and positive pressured to exclude contaminants, and every surface is sterilized. A team of physicians and nurses all wearing sterilized gowns, gloves, and masks, administers general anesthesia that renders the patient completely unconscious and relaxes all muscles. The surgeon makes a precise incision through tissue layers that are clearly visible under bright lights, uses sterilized instruments to identify and repair the obstruction, closes the incision in layers with dissolvable sutures, and the patient wakes in a recovery room where vital signs are continuously monitored. Prophylactic antibiotics prevent infection, and pain medication is administered intravenously. The modern patient will likely go home in 3 to 5 days and return to normal activity within weeks. The difference is not merely technological but represents a complete transformation in understanding what surgery is, why it works, and how to prevent the complications that made medieval surgery so frequently fatal. The story of surgery's transformation is ultimately a story about how difficult it is to see beyond the paradigms that structure our thinking. Medieval surgeons were not stupid or cruel. They were intelligent, dedicated practitioners working within a theoretical framework that made sense of the evidence they could observe with the tools they possessed. They saw that some wounds developed thick white pus and healed while others did not, and concluded that pus was therapeutic. They saw that many patients died after surgery and attributed this to pre-existing humoral imbalances rather than to anything the surgeon did. They observed that pain seemed universal in surgery and concluded it was simply an unavoidable aspect of treatment. Each of these conclusions was logical given their starting assumptions, and those assumptions were inherited from authorities whose wisdom had been trusted for over a millennium. It took the accumulation of new observational tools, new theoretical frameworks from chemistry and biology, new statistical methods for analyzing outcomes, and the courage of individual practitioners willing to challenge orthodoxy before the old system could be dismantled and replaced. The millions who died from surgical infections before the advent of antisepsis were not victims of cruelty, but of ignorance, and their deaths were the price paid for knowledge that now saves millions of lives every year. Modern surgery stands as one of humanity's great triumphs, precisely because it was so hard-won, because it required overturning centuries of confident belief, and because it demonstrates that even our most authoritative knowledge can be completely wrong in ways we cannot see until entirely new frameworks allow us to perceive reality differently. The medieval surgeon did his best with the knowledge available, and the fact that his best was catastrophically inadequate should make us wonder what aspects of our own medical practice will seem equally barbaric to physicians 300 years hence.